Hello, everyone. First of all, a warm welcome to all the listeners and viewers. This is a podcast with Dr. Tushar Mehta, an orthopedic surgeon and a noted faculty of orthopedics at DAMS. We will later on share the video with you to give you a visual as well. In this podcast, we will ask him how a first year PG resident should approach in the field of orthopedics. So, my first question to you, Dr. Mehta, is what is the most basic skill required for a first year PG resident?
Well, first of all, thank you so much for calling me in for this. And now coming back to your question. So your question is that what's the most basic skill required for any first year PG resident of orthopedics? To be honest, that's the only skill that we all live for, what we all wish to achieve, and that is the clinical skill. Now, when I say clinical skill, that simply means that you should be capable enough to deal with your patients, whether in emergency or in elective cases, so that you leave no stone unturned for their benefit and for their medical treatment. So the crux with which I would like to start this podcast is just one thing, and that is clinical skill.
All right. My second question to you is normally they say that orthopedics is a branch which has got huge workload and it requires immense power and muscle. Is that true, Dr. Mehta?
See, I'll tell you something. I'll give you a kind of trailer for your question. When we talk about orthopedics as a subject for entire medical student community, when we talk about MBBS as such, orthopedics is nothing but considered to be a subject which is usually as in final year. It is given a reputation of a short subject except for a couple of medical colleges. Otherwise, everywhere it's a short subject. It carries a value of somewhere around 30 marks. All right. So this is the basic thing that every MBBS student knows, and this is what is the value of orthopedics. Now, when you talk about taking post-graduation in orthopedics, it becomes altogether a change because you choose a branch, you decide to live your entire life with it, in which you go from a short subject of 30 marks to a big, huge subject with so many books, with so many terminologies. And I totally, when I say this, you believe me that even understanding of that terminology is so tough in first couple of 6 months that when any surgeon or any senior is saying during the OT and he's yelling at you, flex, 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 you take at least 5 minutes to understand that whether he's asking you to flex the hip or the knee or the foot. So that is something that every PG resident in first year who has already joined or is about to join should understand. Now, coming to this, I have made this pretty clear to you that it is a kind of a huge shift and drift where from a short subject you enter into a scenario where you have to deal with a very, very big subject. Because see, when you talk about other subjects of final year MBBS like medicine, surgery, gynae, right, you do read them a lot. They're long subjects, you read standard books, you have an idea of what is asked there. But when you talk about orthopedics, which has just a couple of important topics for a final year MBBS student, that maybe a 5 marks question like osteosarcoma or maybe classification of nerve injury, and then suddenly you enter into a huge, big, giant word of orthopedics. Now, I'll come back to your question that whether this muscle power thing, see, you have to understand something that definitely it requires stamina, it requires kind of inbuilt stamina. But when I talk about is that muscle power really important, or is that bulk is really important, I'll use this slide to make you understand. Can you see a JCB machine? The entire India is crazy about JCB and making beams on it. Now you see this guy who is working in that JCB. So this is an orthopedic surgeon. He is not digging this ground. He is not, an earth mover. It is the machine. So we are the man behind the machine. To operate this machine, do you think that he has to have, immense biceps and triceps? No, that's not important. So basically our tools, our implants, our instruments, they look bulky to people. And that is why a myth is there that you have to have a good physique, you have to have a good muscle power. And, I would like to use this opportunity of having a word with you to tell all the people people who are messaging me on various social media platforms that I'm lean and thin and I'm of this much body weight, and do you think I'll fit into this branch? Guys, please don't worry. Just think about this man. I mean, probably, JCB machines are not run by WWE, people. So you understand? So this is the person who's the man behind the machine. The machine might appear bulky to you, but believe me, we have sophisticated instruments these days in the operation theater. This is not an era of 1980s where the entire traction has to be applied by the surgeon himself. So girls are coming into orthopedics. I'm sorry I'm giving you a very long answer, but I would like to use this opportunity to inform all the girls as well who are aspirants for this branch of orthopedics. Last year we had around 18-19 girls. I mean, that of course I know, since I'm a faculty for PG aspirants, that they have joined orthopedics in different parts of the India, and this year also we are expecting a lot of girls to join orthopedics. So this is just a myth about this muscle power and all those things.
Well, here goes my question number 3. There is one more thing attached to it, that it is a branch of emergencies where residents, surgeons have to work hard all day and night. What's your take on that?
See, again, I would like to clear this air about emergencies here. In orthopedics, believe me, there are very limited emergencies. We don't have that quantum of emergencies. I mean, I can show you probably, we deal, I mean, there's something only that can wake me up right now. I'm talking about my status right now. So there's only a couple of things that can wake me up at 3 a.m. right now, and one of them is probably a traumatic amputation, maybe an open fracture, or maybe a surgical emergency like life-threatening septicemia because of a focus in one of the bones or joints. So probably we have very few emergencies in which we have to operate like at the middle of the night. I mean, in fact, I would like to say that other people like physicians, cardiologists and surgeons, they deal with more emergencies than we do. I'm sure the listeners must be aware of the fact that even whenever there is any fracture, like there's a common roadside injury that happens, like you are going out for a walk and you have a pothole and you don't see that, and your foot goes inside and gets twisted. You go to any orthopedic surgeon, you rush to him in the emergency, right? He examines you, he gets an x-ray done, right? The only thing that he tells you at that moment is get a plaster applied, or maybe get a crepe bandage and take this painkiller, apply the cold pack and go back home. So do you think that orthopedic surgeon has to operate you then and there? No. Why? The simple reason, swelling. So majority of the trauma in orthopedics associated with swelling, except just for a couple of things that I've already mentioned. So I mean, of course, as a resident, you have to be there in your casualty, you have to be there in your emergency 24/7. But when you land at a particular platform like the way I'm living right now, I mean, I don't think that I will have to wake up at 3 a.m. every morning to attend a patient. I don't need to perform any emergency surgeries, except for exceptions that I've already mentioned, like open fractures or amputations or pelvic fractures, which are basically dealing with life-threatening conditions. So as far as emergencies are concerned, I think surgeons and gynae people and physicians and cardiologists and neurologists, they deal with more emergencies than we do. I mean, this is my personal take. We as orthopedic fraternity also, we might have a different approach to it, but this is my personal take that I've given you here.
All right, so moving on. I do not have a question for you this time, but what's that one guru mantra, as they say, you wish to give to the first year PG residents?
Okay, now that's very interesting. See, I have always been telling even to the PG aspirants, and this I would like to share with the first year residents as well, that there's only one thing, that if in doubt, please ask. If you are unsure about anything, puzzled about anything, lost about anything, confused, unclear, or even baffled, please ask. I'm sure if you are able to see the slide as well, always seek knowledge. So please do ask your questions. Asking a question doesn't belittle you. Asking a question in front of your peers doesn't make you inferior. Asking a question gives you more confidence. Asking a question is not shaming yourself in front of your seniors or your professors. When you ask a question, whether it is pertaining to the logic or not, whether it is silly or even it makes a sense, doesn't matter. What matters is that you should be awake, aware, alert. And I promise you, in that manner you will only arise. So to reach a particular level, to come up to a particular level of capabilities, abilities, you have to be awake, aware, and alert. And if you really wish to be awake, aware, and alert, the only thing that I've already told you is to ask. So keep asking questions. Even if you don't get a proper answer from a senior, doesn't matter. Even if you get a bashing from a senior might tell you, oh my God, you don't know this, even you don't know this. What have you done in your MBBS? What have you been taught in your MBBS? Doesn't matter. We all have gone through this process. We all will go through this process. It's a human tendency. But please remember, these 4 A's are very, very important. So this is one Guru Mantra that I would like to give to all fresh residents, that please ask your doubts.
Wow, that's a lot for the residents to imbibe, and I'm sure that they do value this. So, moving on, Dr. Tushar, I feel that when a medical student joins a surgical branch like orthopedics, there is always an adrenaline rush of going to the OT. What's your take on that? I mean, any suggestions in particular?
See, for this, what I will do is, okay. So what I will do is that I will divide this into two parts. One, I will give you some do's and don'ts, or rather, probably I'll give you more do's, that what one should do as far as emergency is concerned. I mean, see, you have to understand that when you join as a first year resident in orthopedics, the significant part of your time that is, that goes in OPD, of course, that's from 10 to 2 or 9 to 5 or 9 to 4, whatever. But after that, what is most important is that you go to an emergency, you spend your time in emergency. And then what is the other thing apart from emergency? Ward. So I'll answer your question. I'll divide it into two parts. One, I'll be talking about emergency ward. Second, I'll be taking OT. OT I'll be taking next. So first of all, emergency. Minor OT, as we can say. So all the first year residents who have just joined or who have already joined and doing their residency, even they might have entered into second year, those must be having a basic idea of it. You should be very much clear about the various splints, the tractions, the casts that are being applied. You have to be observant. You have to observe them as best as possible. You have to imbibe the principles behind. And now something that I would personally like to mention here is the basic investigation. I myself, I have done this. I'm not talking about anybody here else. I'm myself done this, that I was asked about a couple of reports of blood count, or maybe that was something related to maybe LFT, I think. And I ignored it. My HOD asked me that what is the bilirubin level and all those things in liver function test. And I was like, as an orthopedic resident, I mean, I'm not concerned about LFT. And the next day, he asked me again, and I said, I don't know. He said, you know what, the patient is on an antibiotic which can cause hepatotoxicity. And that's why I wanted you to keep a watch on it. But for 2 consecutive days, you were not even concerned about that. All you were concerned about was just to write continue same treatment in the file. So on that day, I realized that yes, even the basic investigations are very important. So as a first year PG, you should be aware of all the values of the basic investigation. You have to be keen in observing all those values, what I mentioned in the file. And I would request you to keep them into your head as well. So that if anybody asks you like in an impromptu fashion, you should be able to tell. And now coming to the next thing, that is about the X-ray. I would like to use this opportunity again to tell you something very personal about it. I was asked to write an X-ray. The patient had a swelling in hand, so I wrote an X-ray, like X-ray of the right hand, AP and lateral. And then one of my seniors came and he told me that for hand you need to get an oblique view. I said, but that is the job of a radiographer to find out. I mean, the X-ray technician to find out. He should be, he should be aware enough to, know that he should do an oblique view. So that senior of mine, and of course he was never so kind to me, he said, okay, come with me. He took me to that X-ray room. He asked the radiographer to come out, and then he said, you have 10 minutes, get this X-ray done. I mean, do this X-ray on your own. You have to make sure that the positioning is perfect and everything is perfect, and you do this X-ray. So on that day, I realized that it takes a minute to write down an X-ray, but it takes at least 15 minutes and so much amount of struggle to get that X-ray done, particularly if the patient is a case of a fracture. He's having pain, he's having swelling, he can't move that limb. So on that day, I realized that filling up of an X-ray, writing an X-ray, prescribing an X-ray is important, but what is more important is that you should know how it is done. You should actually arise from the ground level, from the grassroots level. So you should go to the X-ray room as a first year PG. You should talk to the radiographer, the X-ray technician there. You should have a cup of tea with him. You should ask him that how he is doing all these X-rays in different positions. And believe me, if I say that, he's going to be probably the first teacher in your department, and you don't even consider him as a part of your department. So this is something important. Now, after this, if I take you towards the emergency care, I mean, believe me, there's only one thing which is lacking in our medical service right now, particularly in I should not be naming it, but in a certain section of our medical community, there's only one thing which is lacking is communication. If you know the medical communication, if you know the sympathies and empathies, I mean, you can do wonders, because I'm sure that all you are doctors who are listening to it, and you are aware of the fact that a good doctor is that who treats the patient. But a great doctor is that who treats the patient, the psychology of a patient. So we are not here to treat the disease. We are here to treat the patient who has the disease. So communication is important, primary care is important, staying alert is important, making sure that all the things are properly taken care of. This is important. And now, if I take you towards that the OT thing, I would like to say that you have to be observant, you have to be keen over there as well. So that is again something very, very important. Like I don't know about you, but the one dress that has always fascinated me, if you can see the slide, I don't know whether you can see that or not, but if you can see, then the left part, I mean, that is showing you a dress. I think that's the most wonderful dress that one can even aspire for. So in the OT, in first couple of months, I always advise, and my single opinion is that you should be proud of it, that you are able to don that. And of course, you should learn the basic principles of antisepsis, scrubbing. It's not an overnight journey. We don't we don't succeed overnight. We have to give our hard work, our input into it. So learn the basics, learn the scrubbing technique, learn to know how to behave inside the operation theater. Try to understand what is a laminar flow OT. I mean, if you are joining in a medical college which has all those facilities, so try to understand what is a modular OT, try to understand what is a laminar airflow, try to understand all these basic things, and then you should, I think, move ahead. So that is why I have divided your question into two parts. One is how one should behave in emergency ward, and second thing is OT, the basic requirements.
Okay. Any books in particular you wish to suggest?
Yeah, that is one question that is asked to me almost probably these days, since the first round of counseling is over. So I think this question is asked to me on a hourly basis. I'm getting so many messages. So what I've done is that I've tried to inculcate and include this slide which should show you all the visuals, and I'm sure if you can see that on the left hand side there's a book by John Chanley. This is a beautiful book. It tells you how to do close reduction of the fractures, and it gives you a basic insight about it. This is something that you should buy even before joining. The second book that you see in the middle is about tractions and appliances by Stewart. Something again that I would request that you buy this book even before joining. One small tip before I go further: these books are available on Amazon, and you can order from there. And considering the scenario of the country right now, I'm sure they won't be able to deliver it, but yes, once this gets over, you can do that. So Stewart is very important, Chanley is very important, and the third book that you can see on the right hand side, many people they find it very difficult to absorb that how SDAS is important. There's a significant section of orthopedics in SDAS. SDAS is something that we all have read in our MBBS, so please do read SDAS. It contains one of the finest element of orthopedics explained at a clinical level. So these are a must. Like I would say, these three are a must even before you join. Now, coming to a proper first year, the previous three books are a must. Now, even these books are a must, which I'm going to explain in a couple of slides further, but I will tell you the value of it. Like on the left hand side, if you see, it's a pocket book, as the name suggests, Handbook of Fracture. It is by Kowal, like we call it Handbook of Fracture by Kowal. So it is a very small book. It is a handbook, and you can carry in your pocket of your apron if you wear one. So orthopedic residents don't prefer to wear aprons and stethoscope, but if you wear one, then you can keep that over there. And this has all the important classifications of all important fractures, and the moment you see a fracture in emergency and you get 5 minutes, maybe anywhere in any corner of the room, you can just open that fracture, read the classification and the basic principles of management, and that will give you the best memory of that. On the right hand side, you can see another book, Surgical Exposures in Orthopedics. It is by Stanley Hoppenfield. I would mention that I was very passionate about this book, Stanley Hoppenfield. It gives you all important surgical exposures and approaches, how to approach a particular part of the limb. It has limb-wise section like upper limb, lower limb. It has different approaches. And I had a practice which I would like to share. I used to keep this in my locker. Like I had a locker inside the operation theater complex. So I used to keep this in a locker. Before any case and every case, I used to just open the book, read the surgical approach, read the basic anatomy, the clinical anatomy given in this. So two books I've shown here in the slide. On the left hand side, Handbook of Fracture by Kowal, used to carry every day in my OPD and emergency duty, and Hoppenfield was a must in the OT locker, which I used to access before the surgeries. Then these are two books. I mean, see, they are called, they're called the Bible of Orthopedics. One is the Campbell Operative Orthopedics, and on the right hand side is Rockwood and Green. I would suggest that buy Campbell. You should buy Rockwood as well, but start going through them only after 6 months. And Campbell is something that you cannot finish from first page to last page. I mean, you cannot just wake up in the morning on a Sunday and okay, I am free today and let's start with the first page of Campbell. Please don't do that. That's not a good and correct approach to read Campbell. You should read Campbell only case wise. Like you see a surgery, you come back, you read Campbell, you go through it, you will correlate with some of the steps with what is written in the Campbell. Then you start thinking about the rest of the surgery. So you will have a visual correlation of what you have seen just now in Campbell. And right hand side, Rockwood and Green. To be honest, my peers and my seniors will suggest you about this book, but I would say keep this as a reference book. Do read this, but keep this as a reference book. And I hope you remember that I shared this book of Kowal with you. Kowal is kind of a small pocket book of Rockwood only. Then, considering the Indian scenario, then we have a very important man in the history of orthopedics called Dr. S.M. Tully. And considering that India is a very important area for the tuberculosis of the musculoskeletal system, then Dr. Tully's book is a must for all of us. It's a definite must for all of us. And on the left hand side, Apley and Solomon's, this will clear some of the basics of orthopedics that we have, and I think that should always be helpful to you to clear the basics and the cold part of orthopedics. So I think I've given you a long list. Don't get scared by this, and please do buy these books and start reading them.
So how do you advise about the online sources, articles, journals? How to go about them?
Yeah, see, this is important. You have asked a very good question. The articles and journals are concerned, there's one thing that we used to follow. I mean, I still follow. I have a subscription which is active even in these days as well. There's one journal that we follow that's called JBJS. It's called Journal of Bone and Joint Surgery. It has got two versions. One is the British and one is the American. You can take either of them and you start following JBJS. Another one is the OCNA. I was, to be very honest, more fond of OCNA rather than JBJS, but it's a personal choice. OCNA stands for Orthopedic Clinics of North America. I think these two online journals are really important, and you should start following them right from the first year itself, because I don't know whether it is going to happen with you or not, but in your final post-graduation exam, there are usually four parts of that exam. I mean, you have to understand that there are two theory papers. Like there will be a theory paper, there will be four theory paper, two in first day and two on the second day. One of those parts, like there are four papers now, so one of those papers will have some section of recent advances in orthopedics, and believe me, those recent advances are given in JBJS and OCNA, and they are, they're the best. No other journal can mention them better than JBJS and OCNA. I think you asked about online sources as well. So I have personally followed OrthoBullets a lot. There's a website called OrthoBullets. You can see that on web. Then I did follow AO. I do follow even now AO Trauma. That is an online website. AO is an international body of orthopedic surgeon. Quite user friendly, quite reliable. We do follow that a lot. So I think these online sources should help you.
Okay. How can we talk about something that bothers the medicos the most? So while joining the residency, I mean to say the harsh, bitter yet inevitable truth. How difficult is this with seniors and all, long working hours?
I think probably that's the elephant in the room that needs to be addressed right now, because many people who have been allotted orthopedics but they're yet to join, they're a little afraid of the question that you have just asked. Quite a valid question. Before I address to your query, I would like to share something that I've always believed in, and I've told my students and my colleagues even, that anything that doesn't kill you has to make you stronger. So definitely residency will include long working hours. It will include a tedious working environment, and definitely being an orthopedic surgeon, please get tuned yourself to different types of scoldings. And believe me, scolding will always be in the native language. So you have to understand the human psyche. If you are angry inside the operation theater, you will scold only in your native language. And if you join post graduation in a state probably where you don't speak the native language of the state, that's a blessing in disguise, that you will not get to understand the scolding even. But get ready for this. But there's a catch to it, and I would tell you about the catch also. I can explain you the thing that there's only one thing that you should break the ice. With whom? With your seniors. You have to build your rapport with the seniors, relationship building with the seniors. You have to believe in the hierarchy. Sometimes you have to adjust yourself, you have to tune yourself, you have to accommodate yourself to the hierarchy. You have to, and please believe me when I say this, that the relationship that you make in your residency, they last the longest. I mean, still, I'm in most awe of my couple of my seniors who have trained me, who have helped me, who have guided me in the first interlocking that I did, or probably in the first plating that I did. And same goes for my juniors as well. Recently, I had some work in one of the corporate hospitals in Noida, and the person who helped me the most was my immediate junior. So this hierarchy is very important. In medical colleges during MBBS, we don't have that much amount of ragging these days, or probably I'm not supporter of ragging, but I wish to mention here that interaction is very important. Staying aloof is not a possibility in a surgical branch. You have to have a mentor, you have to have a guide, you have to have a senior who has to believe in you, and you have to believe in him or her, whatever. So try to break the ice and make a relationship. Relationships do exist, and that is going to help you a lot. So I think that's probably something that is going to help you if you start working for it. Being an introvert is probably your nature, but talking to people in your department is going to help you. So I think that's about it.
So, how do you suggest them to prepare for fellowships and SRships?
See, fellowships and SRship is something different. I mean, of course, we can talk about that. But before talking about fellowship and SRship, I would like to extend my previous answer. I'm sorry, can I do that?
Sure, go ahead.
I have already mentioned the rule of communication. I hope you remember. So communication really help. It does help not only with your patients, but with your peers as well, with your seniors, with your colleagues, with your professors and everyone. And there's one more thing that I would like to mention here before I go on to the next question, that management skills. I mean, this is something that people don't talk about. This is something that is traditionally not taught in our medical teaching. I mean, we are not taught about this because a doctor is supposed to be a doctor, and a doctor is supposed to be a healer, and a healer is supposed to be empathetic. I know that's fine. But there's one more aspect of it, management. How do you manage? Like, I'll give you an example. You have to get a clearance for a patient for the surgery to be done. So you have to deal with, an anesthetist. So you should be able to have that management skill to get your job done from an anesthetist, you get your job done from a nursing staff, you get your job done from a lab technician, from an intern, from a patient, from his relative, from his attendant. You have to get your consent signed, you have to explain all those things. So technicality, I mean, if you can see on the slide, technical skills is different, interpersonal skill is different, conceptual skill, okay fine, you're good with concepts in your study, but what matters the most is the management skill, because when three of them combine together, you get the management skill. And I think personally that these 3 years of post-graduation, they're the best period for you to learn the management skill, because in India you have to understand, or probably for any part of the world, that doing a job is easy, but getting a job done is a little difficult. So these 3 years can can teach you that. And if you start doing that, I think that should be of really help. So now, I'm sorry I had to extend my answer. Now, coming back to your question, what was the question, by the way? I'm sorry, I missed it.
How do you suggest them to prepare for fellowships and SRship?
Oh, yes, a good question. Although, what I would say is that any first year PG resident right now, if he is joined or if he is joining, please focus on what you have in your plate right now. Old saying, very old saying, bite only what you can chew. So do whatever you have in your hand right now. But still, I know aspirations and desires don't let you sleep. So I would say that senior residency is very important. SRship is very important. There's a trend also that has been observed that just after finishing the 3 years of post-graduation, people, I've seen that in my juniors as well, even in my colleagues, they eventually and immediately they leave off for a fellowship. But I don't think that is advisable, because straight away going for a fellowship, that gives you kind of a tubular vision. Okay, that's fine. Some people will not agree, me saying this, but I think that gives you kind of a tubular vision. So senior residency, SRship for maybe 2 years or 3 years in a government hospital or a medical college or an academic institute where you have enough workload, I think that is really helpful and that is going to be of immense help. So according to me, that is very important. So there's one more question that is I would like to address here, that I'm getting a lot, that sir, I'm going to join orthopedics in a private hospital or in a private medical college, and I will not be exposed to that much amount of a workload. What is your suggestion for me? So guys, my same suggestion is for you as well, that please, after that thing, you have to prepare yourself for an SRship and you have to work hard in that SRship. So I think that should really help here. In fact, there are subspecialties of orthopedics. Like you have asked a question on fellowship, right?
Yes.
So for fellowship, I would like to share the slide also, that there are many fellowships which are available. There are fellowships in trauma, plasty, hip, pelvis, spine, deformity, pediatric, foot and ankle, hand, sports medicine, oncology, infection and non-union. Okay, that's I've written here, but that doesn't make any sense because there is no other fellowship in infection than non-union. But yes, we do have an arthroscopy and people are doing that a lot. So for all the students who are asking me again and again, these are the subspecialties that we have. It's very important to do a subspecialty practice, particularly if you're planning to reside and establish yourself in a tier 1 city like Delhi, Mumbai, Kolkata. So that's very important. So these are the subspecialties. But please listen to this carefully, that after 3 years of your PG, you have to first prove yourself as a good senior resident, because independent decision making, when to operate, when not to, when to get in a surgery, when to get out of that surgery, I think that is something that you acquire as a skill only in SRship. Because as a postgraduate resident, you're always shadowed by someone. There's always someone having your back. So you develop a persona of your independent skill only as a SR. And yes, after an SRship, the kind of work that you're doing, I have shared the list of subspecialties. You try to correlate and introspect, and then you understand that which field you think that you fit in, and then you can go ahead with that.
All right. So how do they upgrade themselves along with the journey of being a PG resident?
See, for this, I would like to tell you that we have a standard association called AO. That's, I've already told you, the International Body of Orthopedic Surgeons, that considered to be the gold standard for all of us. So AO carries a lot of courses. There are basic courses, advanced trauma courses. We as residents have been joining the basic courses, and after that we joined the advanced course. So I would right now, this is probably not the correct platform to tell you about those courses. Probably we can be in touch once you're done with your post graduation, but just to have a fair idea before entering into a field, you can just know that there are some AO courses. You can do that. Apart from that, upgradation also means that getting yourself attached to the regional orthopedic societies. We have various orthopedic forums and societies in India. Probably Delhi has got one, Bombay has got one. We have the Standard and International Orthopedic Association, IOA, that we call. and that is something that is going to be helpful for you. You should get a membership of that as well. Then there is Asia Pacific Association of Arthroplasty. There are many associations, and you can join their CMEs, you can join their PG courses, and you can be aware of what is going on in different states. You have to be socially awake and aware, and you should be well connected with your fellow residents and peers who are into different states doing first year, second year along with you. You have to be updated with them. You will get to know about all these PG courses once you enter, and you will get constant emails and messages, and you can subscribe to them and you can fill in the forms. And there's one more suggestion that I would like to share here, that please take leaves. Keep your academic leaves. Every institute has got a section of CLs and ELs, and EL though is not there, I think, in PG. CL is there, and then you have this academic leave. You have to confirm with your institute, but I think probably you have 20 academic leaves per year. So try to use those leaves for all these PG courses. Spend your money if you have to. Go and attend courses, go and subscribe, go and join. I mean, this is money and time that you're actually spending on building yourself. So this is going to pay you in a long run. So please do that. I think I've answered your question well. So all these things are important. CMEs are important to keep you updated in the long run.
Wonderful. So with this, we come towards the end. Thank you so much, Dr. Tushar. Any last messages that you wish to discuss?
First of all, thank you so much for inviting me to this podcast, and I really enjoyed a lot and had a good time. Last minute message, yeah, probably just one, that you're going into a beautiful field of implants and instruments where innovation is the key, and you will see the branch evolving in front of your own eyes. I have seen that. I've seen a open spine surgery where my professor used to do a laminectomy, and then hemilaminectomy, and then laminotomy, and then endoscopic microscopic discectomy via fenestration. So I'm proud to say that I've seen some part of the evolution, and I'm hopeful that I see this further, and I wish the same for you. And at any point of time that you feel that you are probably getting tired and don't feel yourself well, consider it option for this branch. So just remember, there's something that I've always shared with you all, that your goals don't care how you feel. So it doesn't matter what you feel. What matters is that you are fulfilling your goal and you have passion for this branch, and this is something that you have chosen for yourself. So I think probably that's my last minute message.
Wonderful. Thank you so much for your time.
All right.
That
Thank
will be
you.
the end.
Thank you. Thank you so much, everyone. So I'm glad for this, and my best wishes. This is Dr. Tushar Mehta. Thank you. Thank you so much.